Welcome to H&HN Daily. I'm Susanna Hopsolin, Senior Editor for Hospitals and Health Networks magazine. In rural communities, distance and diverse geography create significant barriers to accessing advanced emergency care. E-Emergency is an innovative concept that uses technologies to connect minimally staffed rural emergency rooms to board-certified emergency physicians and specialists 24/7. Today, I'm joined by Deanna Larson, Vice President for Quality and E-Care Initiatives, and Donald Koziak, Avera E-Care Medical Director from Avera Health in Sioux Falls, South Dakota, to discuss E-Emergency, a unique rural healthcare delivery model. Welcome, Deanna and Don. Thank you for joining me today.
Well, thank you, Susanna, for having us here today. We're delighted to be here today to share with you our Innovation Award.
How does this eHub work?
The eHub is a traditional hub and spoke process. There is a room that has residency-trained board-certified emergency medicine physicians surrounded by critical care nurses and some technology people, located in our tertiary center in Sioux Falls, South Dakota. We're then connected via internet-typed communication that allows us to connect with our outside facilities. Right now, we're currently connected to 62 hospitals in 6 different states. Those hospitals vary in size from small rural critical access hospitals that might be 10 or 12 beds and may or may not have a physician or physician extender anywhere within the community, up to some of our other bigger hospitals that may be like a 200 or 300 bed hospital that are staffed 24 hours a day, 7 days a week by emergency medicine doctors. The system's really easy. You push a button on a wall, a little red button that says push for help. And with that, a phone rings in our hub and we answer the phone. And then we activate the camera. So it might be in my hometown of Wishick, North Dakota. I would say we're in Wishick and I push the camera on, and about 20 seconds after the patient's arrival to that emergency room, we can be live with them in that community. What it means to be live is I'm in the room virtually with that patient and with the nursing staff and sometimes with that provider if they're there at the time. And we can start interacting with the patient and the staff, provide some guidance on initial management and whatever else might need to be done, like calling in staff from home or getting an aircraft available or looking at some x-rays or an ECG with them to help them guide that treatment for that patient.
So it increases the confidence level also of the team that's in the immediate vicinity.
Yeah, I think the feedback that we get is that those that use the system feel like there's another colleague to reach out to. So from a provider standpoint, I think it makes the nursing staff feel a lot more comfortable, particularly taking care of these patients in a rural community. It really helps with recruitment and retention for pharmacists and nurses and doctors and nurse practitioners and PAs to come to a rural community and not think like they're standing all by themselves and all alone. Because emergency medicine, what scares most of them away. The call demands, the emergency care that they have to provide is what keeps them from coming back.
Let me give you a couple of statistics. To date, we have seen over nearly 5,000 patients, and we've assisted with 8,000 transfers. So what that means is that when Dr. Koziak receives a call in the emergency department, either he's able to assist quickly to support, transfer the patient, making sure that they're what we call bundled and packaged as best can be so they arrive in the tertiary facility probably by air flight, one way or another. It could be by ground transport. But the other side of that is really helping them stabilize and understand this patient is really one that can be kept local. So those who are kept local, we've been able to cut the transfer cost down by more than $4 million over this program, and that's just what we can, very quickly ascertain. It could be well past that.
What does it cost to set up a program like this?
Depends on your scope and volume. So I say it depends. The cost of having a board-certified emergency medicine physician, a couple critical care nurses, some support staff, and technology is not a cheap endeavor. So it's hard to make the cost report for a chief financial officer to say, well, this this makes sense for our health system, because it will be a cost center for you. But if you can get past that and you can look at the value to the health system, so as you change from volume to value and quality for a payment system, this is something that, seems like a no-brainer going forward. How can you bring the care that is best capable at the facility there, keep them there when they need to? And it's not always about Susie who hits her head and now she can stay in the local community. Sometimes it's about the big catastrophic things. It's the grandma that has a catastrophic head bleed and everybody wants to be thrown in the back of a helicopter and fly to die in some foreign ICU alone. When we can say, this is something that there's not a lot that we can do for this injury, and let's keep grandma local in your hospital and let the family members be with grandma in her last few hours of life, and makes so that it's not, this sterile environment where she breathes her last breath. Those are some of the stories that I think have changed the practice of medicine more so than the easy, let's take this ST elevation heart attack and send it to the cardiologist. Everybody knows that one is a good win, but there's those intangibles of making care local, making people involved in the process of the care so that it makes sense.
Thank you for joining us today.
Thank you.